Welcome everybody in today's CellTalk presentation. Today, Nuimer Arshad from Renix Life Sciences will present an article titled An International Multicenter Matched Cohort Analysis of Incidental Meningioma Progression During Active Surveillance or After Stereotactic Radiosurgery, the IMPAS study. Numed is a clinical content writer at Renix. He is responsible for writing scientific, medical white papers, and blogs. His work is centered around making complex scientific concepts accessible to lay people. He is currently pursuing PharmD at Lahore University. His writing at Renix focuses on precision medicine for cancer patients. Numed is currently working on GenMap projects and delivering scientific contents that aims to provide gene-centering information for various diseases and their treatments. Renix has allowed him to gain leadership in various projects related to contents. So, now welcome everybody into this talk.
Thank you, Nupur, for the kind introduction. So the study that I'm presenting, it is titled as an international multicenter matched cohort analysis of incidental meningioma progression during active surveillance or after stereotactic radiosurgery, or simply the IMPAS study. It is originally authored by Shihan and others, and I've taken this study from Neuro-Oncology and it was published last year. So before going into the study, let us discuss what is the basics of meningioma and what meningioma is. So meningiomas, they are a type of central nervous system tumors. They arise from layer of meninges or the protective tissues that are around the brain or the spinal cord. So here in this image, you can see that meningioma is arising from a layer of meninges that is covering the brain, and it is going inwards towards the brain instead of going outward, because outward there is skull and it is a much harder tissue. So it is going inward into the parenchyma of the brain or the functional tissue of the brain, and it can cause symptoms due to one, blocking the flow of cerebrospinal fluid or CSF into the ventricles of the brain, or directly pressing against the functional tissue of the brain depending upon where it is located. So these meningiomas, they are very common. They make up about 30% of all the central nervous system tumors in adults, but they are slow growing. And in the WHO classification, they come under the grade 1 tumors. And they are detected when they are asymptomatic on incidental neuroimaging findings. And another thing that I want to discuss in the general background is the stereotactic radiosurgery or SRS. Some of the basics I want to discuss because it is the intervention that they are focusing on in this study. So, despite what the name says, it is not a surgery, it is totally non invasive procedure for destroying the tumors that are located inside the body. Here you can see that beams are coming from three different angles and they are converging on one target. The individual beams, they are not strong enough to destroy the tumor or damage the tumor or any tissue, but once they all combine on the target, they are strong enough to destroy the tumor. It is different from the conventional radiotherapy, because in conventional radiotherapy what you have is a very the doses are very small and they are delivered over weeks in multiple sessions, but in this one all of the dose is delivered in one session only. So this is the major difference from the conventional radiotherapy. And this one also uses the neuroimaging modalities to locate or target on the tumor inside the skull. So some of the present challenges in asymptomatic meningioma treatment is that it is complicated because the tumor itself, it is very slow growing, and the conventional treatment is that to observe the tumor, longitudinal surveillance, and only intervene through surgical resection once the tumor has started growing out, once it has presenting the debilitating neurological complications. But if you go too early and you act too aggressively, then there are some issues that are related with the treatment itself, and these are the neurological deficits that can occur from the surgical resection, because in the surgical resection, depending upon where the tumor is located in the brain, some healthy part of the brain can also be damaged, so that can cause neurological deficits. So it presents some complication, and that whether to go for it early or wait, but waiting leads to development of symptoms, because the tumor at some point it starts growing and it becomes big enough. So there are some challenges regarding what option to take, and the current study aims to clarify some of these challenges by presenting a clear decision on the therapeutic management uh, of meningiomas, the asymptomatic meningiomas, and specifically it is looking into SRS, or the radiotactic surgery that I just explained earlier. It is looking into radiological and neurological outcomes of observation versus the SRS management of asymptomatic meningioma patients. So it will be looking into both of these, and it will be comparing their outcomes in order to give us more evidence into what is the better approach, whether to go for the conventional uh, watch and wait strategy, or act in time using the SRS. Moving on to the methodology, the study design, firstly, I just want to mention that it is a retrospective cohort study, and after that, the study design is they obtain the tumor parameters and the patient parameters from the asymptomatic meningioma patients. They use the data obtained from International Radiosurgery Research Foundation, or IRRF, and under that institution, there are 14 centers across 10 different countries. They obtained the tumor baseline, patient baseline, and treatment variables through the study investigators. They collected themselves, but that data was verified by IRRF and then forwarded back to investigators. They collected the comparable data fields from both the SRS group, also the observation group. In the study population, all of the patients, they were asymptomatic, and they were diagnosed based on the neuroimaging findings. The histology, it was based on the biopsy, and that grade, WHO grade, was grade 1 meningioma, or the very benign type of meningioma. All of the study participants, they were under the age of 16 years old. The patients, they did not exhibit any symptom at the time of diagnosis, which is expected from grade 1 meningioma. And the longitudinal evaluations with serial neuroimaging and clinical assessments were conducted. The tumor progression was defined according to response assessment in neuro-oncology criteria, or simply the RANO criteria. The intervention, as I discussed earlier, it is the radiosurgery, or SRS, and it was all delivered in one session, which is the norm in SRS treatment. The particular instrument that they use is gamma knife, and for the neuroimaging guidance, they use the brain MRI and the CT scan. In terms of outcome, their primary outcome was to define the local tumor control, and that was based on the RANO criteria. And some of the things that they defined were, in order for tumor to be defined as stable, the volume change should be within 25%. It can be negative or positive, but it should not change more than 25% of the baseline volume. In order the tumor for to be pronounced as regressed, the volume decrease should be equal to or greater than 25% of the baseline volume. And for tumor progression, the volume increase should be greater than or equal to 25% of the baseline volume. The secondary outcome, they also looked at the tumor regression, tumor progression, tumor progression-free survival, and development of any neurological deficits. Here they defined the neurological deficits as any symptom that arose from uh, cranial nerve dysfunction. So the cranial nerve could be damaged, and symptom can result from that, or sensory disturbance can be there. It can be visual or auditory, or motor dysfunction. Movement of muscles can be regarded as one of the symptoms. Moving on to the results, firstly, these are the unmatched patient and tumor attributes, and here you can see that the tumor diameter and the volume, they are both greater in the SRS cohort. Now this reflects the real life scenario in which only the patients who have a bigger volume or greater diameter of the tumor, only those are referred to the SRS cohort. This reflects the real life scenario, but this is not good for comparing the two treatment modalities. So in order to compare, we need some sort of similar data, and for that they perform the one-on-one propensity scoring match, and after that they obtained the parameters that were far more relatable to each other or comparable to each other, so that we are comparing apples to apple, and that only tells us which modality is better than the other one. Because in the previous one, in the matched one, you can see these patients that are going the SRS treatment, they already have greater diameter and greater volume, so that also includes the bias against the SRS. So they matched in order to get the very comparable numbers in terms of tumor attributes. Into the neurological and radiological outcomes, and these are for the unmatched cohorts. And even in the unmatched cohorts, 99% tumor control was obtained in SRS. This is including the biases that were there in the unmatched, and still the SRS cohort performed better. And the neurological deficits, they were also in favor of SRS cohort. But once they performed the one-on-one propensity matching, they uh, got further result into the favor of SRS, and as you can see that it is 99.4 in favor of SRS, and 62.1 the tumor control is there for conservative management. And also the neurological deficits, they are far greater in the conservative management, considering that meningioma itself, it doesn't cause a lot of neurological deficits, so this difference can be considered of significance in the context of the disease. So moving on to the secondary outcome in the results, that is the tumor progression-free survival, and here you can see a Kaplan-Meier graph, and it is showing the above line indicates the SRS cohort, and below it is the observation cohort, and this is for the unmatched cohorts, and it is showing in favor of the SRS cohort. This is only for 5 years. If they had gone more than 5 years, they would have gotten a better clinical image, and this is one of the limitation can be mentioned later on. But still, the 5-year follow-up, it is showing in favor of the SRS cohort, even in the unmatched. And if we go to matched cohorts, it is still in the favor of SRS in terms of tumor progression-free survival. Now, moving on to the discussion, as we know that asymptomatic meningioma patients, they typically demonstrate a very slow progression, so their treatment is challenging. But here in this study, it is clearly shown that SRS offers a far better tumor control, and also the onset of new neurological deficit, it is lesser in the SRS treated patients. So they followed up to 5 years, and they found that even the tumor progression, it was lesser in SRS treated patient as compared to the conventional patients, conventional treatment, which received the conventional treatment. So here SRS clearly shows benefit over the conventional treatment. Now, into the strengths of this study, first of all, it is including participants from 10 different countries, and the sample size is quite large. And it is also considering the it also matched the participants based on the one-on-one propensity scoring. This does not exclude some of the inherent limitations that are there in the retrospective observation study, but within staying those limitations, it offers a better statistical outcome. So moving on to the limitations, the first limitation, as I mentioned earlier, the retrospective design, it has some inherent potential for bias and confounding factors, it cannot be considered equivalent to the evidence that we get from a randomized clinical trial. So therefore, that can be considered as one limitation. Other limitations are the patients, they were all over the age of 16. There was no pediatric patient in that. They did not assess the quality of life or cost effectiveness of this care. And another limitation can be mentioned is they only followed the patients for 5 years only. If they had followed it for more years, because in context of meningioma, the disease can progress after 10 or 20 years. So if they had followed for a longer period, it would have provided a much better clinical picture. So in conclusion, SRS, as we saw from this study, it offers a better clinical management, and it also has lower instance of the neurological deficits, and the tumor control is much better in SRS. This study also highlights the needs for a clinical trial to compare the SRS with the conventional treatment of asymptomatic meningioma patients to get a better picture of how do these two modalities compare. But from this study, there is some evidence can be extracted in favor of SRS. So impact of this study is in the management of asymptomatic low-grade meningioma. It provides evidence in favor of SRS for this patient population, and it also highlights a need for a larger randomized clinical trial so that we get a better grade of evidence uh, in comparison of these two treatment modalities for asymptomatic meningioma patients. Thank you.
Thank you, Nuimer, for your nice presentations. We have time for questions from the audience. There is already one question from Vijay. Vijay wants to know, will adoption of SRS add to the cost of treatment, and will it be deliverable in the developing and poor countries to wider patient population?
So one of the limitation is they did not assess the cost of this treatment. Uh, the treatment with the conventional strategy is that you have to wait and watch if the tumor grows or not. But if the tumor grows, then you'll have to go to the surgery. And surgical resection, it can be expensive, but depending upon whether or not SRS is available in that country, it can also be expensive. So they did not compare these two in terms of their cost, but I think the further studies can compare that and give us a better answer on that.
I hope it clears Vijay's doubts. I have a question. This treatment treatment is a targeted treatment. It is targeted to the tumor site only. Still, does it leave any side effects?
Yeah, there are some treatment associated side effects in SRS as well, but as we saw in the slide, that it was targeting from different angles, and all of the individual beams, they were not strong enough to cause the tissue damage to brain or any skull or hair between that. But once they converged on one target only, the dosage was increased, and only that point was receiving a much bigger dose of radiation. So that was only affected, but it can have some issues on the healthy part of brain as well. So there were associated some new neurological deficits in the SRS as well, as we can see here. See, there are some new neurological deficits, and uh, it can be associated with the growth of tumor after the treatment, but it can also be associated with the intervention itself. And here, if we look at this other diagram, the tumor itself is not growing a lot in this patient population. So we can say that these are coming from the intervention itself, but it is hard to be confident on that. They did not provide the direct effects of intervention on the participants, but from the graph here, we can say that the tumor itself is not growing, but the new deficits are there. So they may be related to the SRS.
Okay, thank you. I don't see any other questions, so let's we look forward for the next presentation. Next presentation will be given by Dr. Vijay Parul from Renix Life Sciences. He will talk about neoadjuvant nivolumab plus chemotherapy in resectable lung cancer. We are looking forward the presentation in the next week. Till then, thank you everybody for your participation.